Now we are going to talk about ataxic gait or cerebellar ataxia. We call it also drunken gait. Most commonly seen in cerebellar disease. This type of gait is described as clumsy, يعني غير رشيقة, clumsy, staggering, يترنح, unsteadiness, move on a wide base while standing still. The patient's body may swagger يتوختر back and forth and from side to side, known as titubation, يتمايل. The gait of acute alcoholic intoxication will resemble the gait of cerebellar disease. لذلك احنا نسميه مرات drunken gait, drunken ataxia. So we have to differentiate between cerebellar disease and alcoholism, looking for features of cerebellar lesion like nystagmus, ataxia, tremor, and etc. with dysarthria. Patients with more truncal instability are more likely to have midline cerebellar disease. At the vermis, examine the gait for ataxia by doing tandem gait. فبنريد نفحص الاتاكسيا لازم نسوي tandem gait اللي هو heel to toe. Ask the patient to walk in a straight line with their heels to their toes. فنمشي على خط رفيع بالقاع مثل خط الكاشي ونشوف if he's able to walk properly or not.
Recognize, and it may be one that you're all familiar with from watching police videos and hopefully not from personal experience, is the cerebellar gait. The cerebellar gait is characterized by a broad stand,
cerebellar gait,
by a wide staggering quality to it.
Wide staggering.
People will tend to fall towards the side of their illness, so
ترنح, and he's
in the cerebellar hemisphere
swaying
left,
or leaning to the side of the lesion, cerebellar lesion.
Still, their trunk may sway like this, and that is called titubation. And obviously they would have problems with all the other cerebellar tests.
Cerebellar ataxia is equally severe when the eyes are opened or closed. يعني إذا فات عينه أو ساد عينه طبعا equally severe. عكس السنسوري ataxia أو نسميه الstomping أو الstamping gait أو الstomping gait أو الstomping gait. Stomp يعني الدوس. As our feet touches the ground, we receive proprioceptive information to tell us their location. The sensory ataxic gait occurs when there is loss of this proprioceptive input. For normally, we depend on proprioceptive, the posterior columns, to tell us the location. The foot raises very suddenly high and then jerk it toward, bringing it to the ground again with a stomp by using their eyes in place of position in an effort to know when the feet land and their location. هنا طبعا الsensory ataxia is more obvious, is more severe, exacerbated on a dark place أو من نقول للمريض غمض عينك, closure of the eyes, so called نسميه stomping gait, since the patient may lift their legs very high to hit the ground hard. طبعا هنا the gait is seen in disorders of the dorsal columns مثل B12 deficiency patient or the syphilis with tabes dorsalis, or in disease affecting peripheral nerve like in uncontrolled advanced diabetes. طبعا cerebellar ataxia causing severe ataxic gait, وهنا نسوي لهم Romberg test, نقول Rombergism أو Romberg test is positive by asking the patient to put their feet together, يعني يوقف وقفة الاستعداد, keep their hands by their side and close their eyes. فمن يغمض عينه طبعا راح يترنح ويوقع. Be ready to support them in case they are unsteady. This is a test of proprioception. هذا هو proprioception test, not of cerebellar disease. Swaying with a correction is not a positive result. So in unilateral cerebellar disease, the patient can veer towards the side of the lesion. Although this may occur in cerebellar disease, falling without correction is abnormal and indicates unsteadiness is due to sensory ataxia from lack of proprioception rather than cerebellar ataxia. فإذا بالcerebellar ataxia ما يفرق عنده إذا كان يعني الغرفة مظلمة أو يغمض عينه أو لا، يترنح بس الترنح قليل. بس remarkable ataxia on close of the eye or movement on a dark place in case of sensory ataxia when there is loss of proprioception.
Many people think of the Romberg test as being a test of cerebellar disease. The Romberg test has nothing to do with the cerebellum. The cerebellar patient is already swaying, and it gets a lot worse when you have them close their eyes. But the Romberg test is really a test of proprioception. When you and I are standing like this with our eyes open, we are getting signals from our joints to tell us where we are in space. If, however, you have a problem with proprioception because of your peripheral nerves or posterior columns, then you're relying on your eyes to tell you where you are in space, and therefore, the moment you ask the patient to stand still and close their eyes, the patient begins to sway, and that is a positive Romberg test.
This is positive Romberg test
to do with the cerebellum.
In cerebellar and sensory ataxia.
Leads me to the other gait related to proprioception. Once again, if you have trouble with your proprioception,
فإذا إذا عندك defect in proprioception راح يصير عندك Romberg sign positive وعندك high
and especially in the
stomping gait.
You might develop what's called a stomping or stamping gait, where you tend to
stomping
walk like this,
gait, stomp,
needing to slam your foot down to get the vibration in your trunk to let you know that your foot has landed. So this gait may be much more prominent in the dark and not as evident.
The other types of gait is myopathic gait or waddling gait أو duck-like gait مثل مشية البطة. Movement of the trunk is exaggerated to produce a waddling gait, a duck-like walk. The body is tilted backwards with increase of lumbar lordosis, and the body sways يترنح from side to side in each step. Abdominal muscles طبعا are responsible for keeping the pelvis level when walking. If you have weakness on one side, إذا عندنا one side weakness فراح يصير عندهم Trendelenburg sign يعني unilateral. But if it is bilateral weakness راح يصير عندنا waddling gait, myopathic gait. This may occur in certain situation, for example in patients with myopathies or in patients with progressive muscular dystrophy, for example Duchenne muscular dystrophy. We see it in bilateral CDH يعني congenital dislocation, bilateral congenital dislocation of the hip. In case of pregnancy and osteomalacia because of muscle weakness, and in lumbar lordosis. Those are the causes of waddling gait or myopathic gait.
This is a gait where the patient develops a waddle, and in order to understand this gait, you have to do a couple of things with me, if you don't mind. Put your hands on your hip, if you would, and appreciate that when you take a step forward, the hip on the side where you are stepping forward, that hip actually moves up. It moves up, and it's a function of having very strong pelvic girdle muscles that allow you to do that. If you have a myopathy, when you lift your leg up to take a step, because you can't hold your pelvis up and stabilize it, there's a tendency for the hip to fall on that side and for you to fall over. And to compensate for that, you lean your trunk this way. So
compensation.
You develop a waddling kind of gait, compensating for the fact that your pelvic muscles aren't strong. You get a waddling kind of gait, leaning away from the side where you.
The other types of gait is neuropathic gait or steppage gait, equine gait, neuropathic, high stepping type of gait in which the leg is lifted high, the foot drops, appearing floppy, and the toes points towards scraping the ground, and when walking, seen in patients with foot drop, weakness of foot dorsiflexion. The cause of this gait is due to an attempt to lift the leg high enough during walking so that the foot does not drag on the floor. If unilateral, like in peroneal muscular dystrophy, or peroneal nerve palsy. Sometimes you see it in spinal problems such as spinal stenosis or disc L5 radiculopathy. If it is bilateral, causes include amyotrophic lateral sclerosis, Charcot-Marie-Tooth disease, and other peripheral neuropathies, such as those associated with uncontrolled diabetes mellitus. So this is a neuropathic type of gait.
Then typically you have to have a high stepping gait, otherwise you will trip on your foot and fall forward. So patients with neuropathy, especially if it's bilateral, will have a gait like this, which is nicely also called the equine gait, or the stepping or steppage gait. And the reason they do this is they can't step forward without tripping on their foot, because they can't really.
The other types of gait is coriform gait, hyperkinetic gait. This gait is seen with certain basal ganglia disorder, including Sydenham's chorea, Huntington chorea disease, and other forms of chorea, like athetosis or dystonia. The patient will display irregular, jerky, involuntary movement in all extremities. Walking may accentuate their baseline movement disorder.
In my mind, strictly constitutes
coriform
these patients are already exhibiting writhing movements, involuntary movements.
It's lower, writhing movement.
And when they walk, they can have the most bizarre sorts of gaits.
It's a bizarre shape of gait. The other types of gait is hysterical gait. It is a bizarre gait seen with hysteria, conversion, reaction. While walking, the foot is usually dragged or pushed ahead instead of lifted. Frequently, the foot is held dorsiflexed and inverted. The pattern rarely duplicate those of neurogenic disability and are usually promptly suspected of being functional. يعني نشوفها functional مع HYS مع hysterical by experienced clinician. As with other pseudo-neurological signs, normal underlying neurological function must be demonstrated. فعادة دول neurological examination will be negative. Dramatic cure is the best diagnostic evidence. Dystonia and chorea are the signs most likely to be mistaken for functional. فمرات يطلع لا dystonia أو عند chorea بنقول عليه هذا functional. Be careful. You may need يعني further investigation including CT scan and MRI. And thank you.